So very good afternoon to everyone. So today we will be starting with the endocrine chapter, and the most important topic which is asked from you student in endocrine chapter is basically your diabetes mellitus. Question comes very commonly on diabetes mellitus, but we will discuss other topics as well like thyroid, osteoporosis, the drugs which act on estrogen receptors, corticosteroid, etc. So today is the agenda of our endocrine chapter. So this is the PDF you can share with your friends as well who need to revise at the last moment. And remember, knowledge is always meant to share. The more you share, the more you learn. Okay? Always remember this thing. So always help your friend always. So when I will be sharing this PDF with you, you can directly tap on this YouTube link. It will direct you to this specific video of endocrine chapter, or you can scan it also. Okay. So it becomes easier for you to read simultaneously from PDF, and simultaneously you can see the lecture as well. Okay. So let's start without wasting any more of your precious time. So first question is, which of the following is the longest acting insulin? Remember, now the longest acting insulin has become Degludec. Degludec, it acts for 42 hours. Earlier, the longest acting insulin was Glargine. It was acting for 24 hours. Now remember, Lispro is the overall shortest acting insulin. It is given by injection. It acts for 3 hours. But if anyone will ask you which is the overall shortest acting insulin, the overall shortest acting insulin is Afrezza. Afrezza, remember, it is not an injectable insulin, it is a nasal insulin which is given by nasal spray, and it acts for 2.5 hours. It just acts for 2.5 hours. So shortest acting injectable insulin will be Lispro, while shortest acting overall insulin is Afrezza. Longest acting now has become Glargine and Degludec. So which insulin is never mixed with other insulin in same injection? Remember, the answer of this question is Glargine. Remember, all insulin, their pH is neutral. They have a neutral pH of around 7.2. Why neutral? Similar to our blood pH, it is neutral. That is why all insulin can be combined in same injection. But Glargine is an acidic insulin. Because its pH is different, it is never combined with any other insulin in same injection. A very frequently asked question. So you already know the answer of this question as well. Now, which of the following insulin is given intravenously for diabetic ketoacidosis? Remember, for the long-term treatment of diabetes mellitus, patient himself or herself can take insulin injection at home, and patient himself and herself takes subcutaneous injection because it is easy to administer in fat. IV injection is not possible as a self-administration. So IV insulin, it is only given in emergencies. And one of the emergency is diabetic ketoacidosis. Another emergency I want to write is HHS, which stands for hyperglycemic hyperosmolar state, a dangerous condition, patient can die. And insulin is also given for one emergency treatment of hyperkalemia. Insulin is also given for treatment of hyperkalemia. So we all know that the insulin which can be given IV is regular insulin. So we can give regular insulin for these three conditions: DKA, HHS, and hyperkalemia treatment. So which of the following is not used in the treatment of insulin-induced hypoglycemia? Remember, for insulin-induced hypoglycemia, either we can give glucose. Now glucose is either given orally or IV. Now just imagine a person had hypoglycemia at home and patient became unconscious because the brain is not getting enough amount of glucose. Patient may become unconscious. During unconscious state, you cannot give oral glucose, and the family member cannot put an IV drip also. In that case, recently US FDA and Indian government have approved glucagon. Glucagon can easily be administered as a nasal spray in an unconscious patient. You can also give intramuscular injection because it does not require any special equipment like IV. So glucagon can be given nasally as well as intramuscularly. Both routes you have to remember. So the drug which we don't give for insulin-induced hypoglycemia will be, answer is adrenaline. Adrenaline is not. The question is asking not used. Okay, not used. Fine. So answer is adrenaline. I hope it's perfectly clear to everyone. Now you know the concept, so you will never forget it. Okay. So an elderly man who has been a known case of diabetic nephropathy, and diabetes is the leading cause of kidney damage, we all know. Now he presented with emergency with palpitations. That means some arrhythmias in on heart. There is some chest discomfort, and ECG shows tall T waves. Now, tall T waves, you remember it occurs in hyperkalemia when there is excess of potassium level in the blood. Because excess of potassium, if enters into the heart, it leads to permanent repolarization of heart. Tall T waves will happen. So we have already diagnosed the patient is having elevated potassium level. Which of the following drug will shift potassium back to the cell? Now remember, in hyperkalemia treatment, if there is excess of potassium in the blood, the first thing which we have to prevent is we have to prevent entry of this potassium into the heart. Otherwise, the patient will have arrhythmias and tall T wave. And the drug which prevents potassium entry into the heart is calcium gluconate. So the first drug given to protect heart will be calcium gluconate. Now what we will do with this elevated potassium level in blood, we can make this potassium enter or distribute into organs like fats and muscle. So if we make this potassium enter into fat and muscle, blood potassium level will fall. So we can give IV regular insulin, because insulin makes this potassium enter into muscles and fat. Now two drugs which can be given is beta 2 agonist, because if you stimulate beta 2 receptor of sympathetic nervous system, they promote insulin secretion. And the drug which can be given instead of insulin is salbutamol, which is also used in asthma. And you can also give epinephrine injection for the treatment of hyperkalemia because they promote insulin secretion. Now the third thing which we can do is make this potassium enter into urine. And the drug of choice is loop diuretics. Loop diuretics, they lose all ions into the urine, so they will cause potassium loss into the urine. So the answer is furosemide. Answer is furosemide. Okay. Okay. Lastly, what we can do, we can reduce the GIT absorption. Suppose this is a GIT. And from GIT, can we say the potassium enters into the blood? Potassium gets absorbed. So we can reduce this GIT absorption of potassium. For this, we can give potassium binding resins. We can give potassium binding resins. The drugs are polystyrene, sorbitol, and a new drug recently got approved. Even if you will not remember, it will be fine. Petiromer. It's a new drug recently got approved for hyperkalemia treatment. They reduce the binding of potassium or absorption of potassium. So can you tell me the answer of this question? Which drug will cause shift of potassium back to the cell? The answer is this one. So go with the answer insulin. Go with the answer insulin. I hope it's perfectly clear the treatment of hyperkalemia. Now let's talk about which of the following drug does not produce hypoglycemia. Now remember, I'll give you a trick. The drugs in diabetes which produce hypoglycemia are only three class of drug. The first drug which causes hypoglycemia in diabetic people is insulin if we take higher dose of insulin. And second class of drug which can produce hypoglycemia is insulin secretagogue. Insulin secretagogue means those drugs which promote insulin secretion. And among insulin secretagogue, we have two classes of drugs. I will write their name first. You don't have to remember the group name. The first class of drug is sulfonylurea. You don't have to remember the name sulfonylurea. And the second class of drug we have is meglitinides. Only these three classes of drugs can cause hypoglycemia. No other anti-diabetic drug can cause hypoglycemia. Now, sulfonylurea can be of first generation, and any first generation sulfonylurea, it will end with the word amide. Let's take an example: chloropropamide, tolbutamide, acetohexamide, all will end with the word amide. Second generation sulfonylurea, they will start with the word gly. They will start with the word gly. Glimepiride, glipizide, gliclazide. And any drug which is a meglitinide, it will end with the word glenide. It will end with the word glenide, like repaglinide, natiglinide. So remember, you just have to remember one trick. Drug ending with the word amide and glenide, they will produce hypoglycemia. And any drug that starts with the word gly will also produce hypoglycemia. So can we say insulin produces glimepiride? It is a second generation sulfonylurea. Glipizide, it is also a second generation sulfonylurea. So the answer here is rest any other drug will not produce hypoglycemia. Okay. Okay. बेटा इससे ज़्यादा ठीक हो जाएंगे मयंक जी. If you will solve this much, you will almost score 80 to 90% if you can remember all these things. Okay, and that depends upon how your preparation was. Okay, so remember, match is not one on one day. It depends upon your practice how much you have done. But yes, as a last minute, if you will see this, you will recall everything. That is the main purpose of conducting this class. So all of the following statement regarding liraglutide are true except. Now remember, in diabetes, any drug that ends with the word glutide, I'm giving you the trick. Any drug that ends with the word glutide and any drug that ends with the word natide are GLP-1 agonist. Now GLP-1 stands for glucagon-like peptide agonist. So let me write certain names like liraglutide, semaglutide, albiglutide, dulaglutide. So they all end with the word glutide. Exenatide, lixasenatide. So they all end with the word natide. They all are GLP-1 agonist. So remember, it is a GLP-1 analog. It's an absolutely true statement. Now, is it given in the treatment of type 1 diabetes? Now, this is a false statement. Because I have told you in regular lectures only, also, in type 1 diabetes, only 3 drugs are approved. Only 3. One is insulin, second is Acarbose, and one amylin hormone, pramlintide. Apart from this, no other drug is approved in type 1 diabetes. Next point is that all these drugs can be given as a subcutaneous injection. The answer is true. Any drug that ends with the word tide, remember, any drug that ends with the word tide is always a peptide. Peptide cannot be given orally because pepsin trypsin will degrade them. So they are given by subcutaneous injection. But a new follow-up, there is a drug known as semaglutide. Semaglutide was first approved as a subcutaneous injection. Yes, it's a tide drug, it's a peptide. But now it is also available in an oral form also. So which GLP-1 is also approved as an oral drug apart from injection? Semaglutide. And these drugs are approved as an anti-obesity drug also because they produce weight loss. So let me tell you which drugs in diabetes produce weight loss. So the drugs which are approved as an anti-obesity drug are 3 in diabetes mellitus. The first you can remember on your mnemonics, still, or better to write, let's write still. 3 drugs which are approved in diabetes as an anti-obesity drug. The first drug is semaglutide. Second drug is tirzepatide. And the third drug which has been approved as an anti-obesity drug because they produce weight loss is liraglutide. 3 drugs you have to remember. Now remember, among them, semaglutide and liraglutide are GLP-1 agonist drug. But a new drug for diabetes is tirzepatide. And there are high chances that this drug might be asked this year in your exam, upcoming exam. It's a wonderful drug. And this drug, remember, it is not just GLP-1. It is GLP-1 plus GIP agonist. So it's a dual drug. GLP-1 is glucagon-like peptide. GIP is glucose-dependent insulinotropic peptide. These molecules, they promote insulin secretion. And among these three drugs, this tirzepatide now, which is a recently approved drug, is overall an anti-obesity drug which causes maximum weight loss. Maximum weight loss is caused by tirzepatide, followed by semaglutide. Okay. Now remember, you must have seen Karan Johar. You have seen Karan Johar. He was so big, है ना? When he was big, his movies were running. They were making a lot of profit. Now he has become so thin, so kechexic, so thin or lean. Now the movies are also getting, flop, है ना? Loss. He has even sold his company also. So that Karan Johar, how he got so much thin, how he lose so much of weight, Karan Johar, he was taking the injections of this drug, semaglutide. But if I'll ask you, if now you want to take any drug to become even more thinner, even before than Karan Johar, you must take tirzepatide. It is even causes more rapid weight loss. Okay? Chalo. So which is the only available oral glucagon-like peptide GLP-1 agonist? We all know the answer. It was a last year MCQ of NEET and FMG both. Has been asked in INI-CET as well as semaglutide. So now understand here, what we have written out here is GLP-2 agonist. It is not GLP-1. It is GLP-2. And remember, GLP-2 is not effective in diabetes. In diabetes mellitus, we give GLP-1. GLP-2, they are given in a different disease known as short bowel syndrome. Because GLP-2, which is glucagon-like peptide, it causes growth of intestinal cells. It causes growth of intestinal cells. Now just imagine you have done some colonic resection or colonic surgery. So you have removed the colon of a person. Don't you think after colonic resection, the bowel becomes short, and because of short bowel, there will be incomplete absorption of food, which can lead to malabsorption in short bowel syndrome. To treat this malabsorption, we must promote the growth of intestinal cells, and the drug which has been approved to promote the growth of intestinal cells is teduglutide. How we can remember? Tedu. Tedu means 2. And glue word is coming. You can see GLP-2. You can remember glue word is coming. GLP-2 analog teduglutide. Okay. Now, the drugs which increase the level of endogenous GLP-1. Endogenous means GLP-1, they are also produced inside our body. And this GLP-1 is also known as incretins. So incretins or GLP-1 which is produced in our body, remember they are degraded by an enzyme known as DPP-4 enzyme. Which enzyme degrades incretin or GLP-1? DPP-4, which stands for dipeptidyl peptidase 4 enzyme. So we have a drug which will inhibit DPP-4 inhibitor. They will increase the level of endogenous GLP-1. And these drugs, remember, they end with the word gliptin. They end with the word gliptin. How we can remember? Gliptin. See, GLP word is coming. GLP-1 word is coming in GLP. GLP-1 level is IN, means increased by gliptin. The name itself will tell you gliptins, they increase GLP-1 level. So the answer now you know very well is sitagliptin. Okay. Lexasenatide is also GLP-1. They will end with the word natide and glutide. They are synthetic GLP-1. DPP-4 inhibitor, they will increase the level of GLP-1 inside the body. So these are the two different types of drug. GLP is glucagon-like peptide which promotes insulin secretion in our body. Now, which anti-diabetic drug does not require dose reduction in renal failure. So remember, which anti-diabetic drugs are renal safe? So let me give you a very important mnemonic that imagine there is a girl Lena. Imagine there is a girl known as Lena and she suffered from, after breakup with her boyfriend, she suffered from PTSD. She suffered from PTSD. So remember, in renal failure, which drug lena hai? The drug which you have to lena hai is always linagliptin. And this is a drug which you should not forget. So linagliptin is safe in renal failure. Okay, this is the most frequently asked question. But last year, linagliptin was not asked. Last year, a new gliptin has been approved, available in India. We commonly prescribe as T for teneligliptin. Teneligliptin and linagliptin are two gliptins which are safe in renal failure. These two you have to remember. Apart from this, other drug we will just write to complete the mnemonic. Pioglitazone is also safe in renal failure. Semaglutide, safe in renal failure. And dulaglutide. So remember, Lena suffers from PTSD. These drugs are safe in renal failure because, okay. Now, all of the following are true about metformin except. So remember, metformin indeed the most important drug for diabetes. It is even considered to be the drug of choice for type 2 diabetes because it reduces insulin resistance. So remember, metformin causes no hypoglycemia. Yes, we know. And metformin has no effect on weight. Yes, it does not increase weight increase. It rather causes weight loss. It causes mild weight loss. So first statement is true. Okay. So you have to find the except statement. It acts by insulin secretion. Now this is a false statement. Remember, metformin acts on liver. Where metformin acts? Metformin acts on liver, and on liver, metformin inhibit hepatic glucose production. It inhibit hepatic gluconeogenesis. So what is hepatic gluconeogenesis? To make glucose from non-carbohydrate source like lactic acid to glucose. This is known as gluconeogenesis. So metformin inhibit hepatic gluconeogenesis. So yes, the third statement is also true. Now, when given with alcohol, it increased the risk of unexplained diarrhea. This was a last year question of NEET. The most common side effect of metformin is unexplained diarrhea because it inhibits bile absorption. It causes lactic acidosis. Yes, the most dangerous side effect of metformin is lactic acidosis. And lactic acidosis, after lactic acidosis, remember, metformin reduces vitamin B12 absorption from GIT, which leads to B12 deficiency, and metformin can lead to megaloblastic anemia. So again, this is a true statement. Go with the option number B. Okay. Okay. No, it is not weight neutral. It causes mild weight loss in obese people. Okay. It's not a weight neutral drug. It causes weight loss. There's a lot of controversy, but believe me, what I'm telling you is absolutely true. It causes weight loss. A patient is receiving insulin, and apart from insulin, he is on Acarbose for the treatment of diabetes mellitus. And this patient, because of insulin, develops hypoglycemia. Which of the following should not be used for the treatment of hypoglycemia in this patient? Remember, if a patient suffers from hypoglycemia, mostly at home, the person rushes to the kitchen, and in kitchen, the most common substance or food to correct the hypoglycemia he or she may find is sugar, table sugar, which is sucrose. But remember, if a patient is taking Acarbose in GIT, this sucrose will not be broken down into glucose because Acarbose has inhibited one enzyme in GIT known as alpha glucosidase enzyme. So only glucose gets absorbed in the blood. So do you think Acarbose can the hypoglycemia will be corrected by sucrose, chini? The answer is no. So you have to give some simplest form of carbohydrate which is not broken down. So for the treatment, either you give glucose or honey, because honey, it also contains fructose, It is also a monosaccharide which need not to be broken down by alpha glucosidase enzyme. So obviously you will not give big complex carbohydrate, they will not be broken down. You will not give sucrose, you will not give table sugar, you will not give starch. Okay. So answer is C. So glucose or honey is commonly found in kitchen. So instead of taking sugar, take honey or take pure glucose like glucon D. So which of the following anti-diabetic drugs act by activating PPAR-gamma? So PPAR-gamma full form is peroxisomal proliferator activating receptor, gamma type. It is present on adipose tissue and it reduces insulin resistance on adipose tissue by promoting lipogenesis. So any drug which is a PPAR gamma agonist, these drugs they will end with the word glitazone, like pioglitazone, troglitazone, rosiglitazone, etc. So the answer is pioglitazone. But remember one follow-up question, that there is an antihypertensive drug which is a sartan, angiotensin receptor blocker. It also has PPAR gamma agonist action. That means it is also good for diabetes. The drug name is telmisartan. An additional question. So which antihypertensive drug has action like pioglitazone, anti-diabetic effect telmisartan? That is why telmisartan is one of the most preferred antihypertensive drug, because most of the hypertensive people they suffer from diabetes also. Now this was a recent question of last year in both NEET and FMG and has been asked in INICET many times. So which drug causes excretion of glucose in urine, glucosuria? The drug which causes increase in flow of urine by promoting glucose and sodium excretion, increase in flow of urine. So remember flow, zin. So any drug which ends with the word flozin causes excretion of sodium and glucose in urine. So the answer out here is canagliflozin, because flozins they inhibit one transporter in kidney known as SGLT2 in PCT of nephron or PCT of kidney, which will lead to sodium and glucose excretion in urine. They produce sodium and glucose excretion in urine. Now, beta, I want to ask you, if there is glucose excretion in urine, don't you think it will increase the risk of urinary tract infection? So the side effect will be UTI, urinary tract infection. Both bacterial as well as fungal UTI can happen. So it can cause both bacterial as well as candida UTI. So the answer is urinary tract infection. Remember urinary flow. Flow means empagliflozin. Flow word is coming. Flozin word is coming. Okay. Flozin word is coming. Understood this part? Yes, it has other side effect also, which I have already told you. Fournier's gangrene. It increases the risk of diabetic ketoacidosis as well. Other side effect. It also increases the risk of osteoporosis because of calcium excretion. It can also cause genital infections like Fournier's gangrene, etc. So, which of the following, this question came this year in INICET and last year in all format of exam. Remember, which anti-diabetic drug is approved for CHF, chronic heart failure, because it has a cardioprotective effect. And last year the specific question came, which anti-diabetic drug has also been approved in CKD, chronic kidney disease, because it has renal or kidney protective effect. Again, the answer is flozins. The best drug we are having right now is flozins. So go with the answer dapagliflozin. Okay, dapagliflozin. So what is the drug of choice for diabetic neuropathic pain? So neuropathic pain, diabetic neuropathy, remember the drug of choice is pregabalin. Many times asked MCQ. And what is the drug of choice for diabetic retinopathy? Remember in retina in diabetes, diabetic retina, there is abnormal proliferation of blood vessels, which you call it as neovascularization. And these blood vessels, they rupture very easily, which can lead to sudden bleeding in retina, and the patient becomes suddenly blind in diabetic retinopathy. Now remember, this neovascularization or new blood vessel is produced in retina with the help of a protein known as VEGF protein. Which protein makes neovascularization? VEGF protein, which stands for vascular endothelial growth factor which causes neovascularization. So we have to block VEGF. So any drug that will block VEGF will inhibit neovascularization given as an intravitreal injection. So the most famous drug is bevacizumab. How it is given? Directly into intravitreal injection. Vitreal injection into retina. Into vitreous humor, it will reach retina. How we can remember bevacizumab? B for blood vessel formation is inhibited by bevacizumab. And you can see E and V word is coming. E and me means bevacizumab is a monoclonal antibody which blocks VEGF, Now, apart from bevacizumab, there are three more drugs which have been approved in diabetic retinopathy. Three more drugs. But you have to remember only bevacizumab. Let me tell you other drugs which have been approved. Ranibizumab has been approved. Same drug. Elfibercept. They all block VEGF. And a new drug recently got approved was pigaptanib. Pigaptanib, APTA word is coming. It's a new class of drug. APTA means it's an aptamer. You don't have to remember right now. Just try to remember bevacizumab for diabetic retinopathy. Now let's talk about what is the treatment of thyrotoxicosis, which is also known as hyperthyroidism in pregnancy, second and third trimester. Remember, it's a very confusional question. Most of you students mark wrong. Remember, there is no single drug of choice for hyperthyroidism in pregnancy. Propylthiouracil, it is the drug of choice for hyperthyroidism in first trimester of pregnancy. And PTU, propylthiouracil, is contraindicated in second and third trimester. Second and third trimester, we don't give propylthiouracil because it is a highly hepatotoxic drug. So in second and third trimester, either you give carbimazole and its brother or active form methimazole. So carbimazole and methimazole are the drug of choice for second and third trimester of pregnancy. But remember, they are contraindicated in first trimester of pregnancy. They are contraindicated in first trimester because in first trimester they are teratogenic drug. They can cause a teratogenic effect known as aplasia cutis. I think this part we have discussed in general pharma. The skin of the child on scalp will not be produced, so we don't give carbimazole and methimazole in first trimester of pregnancy. So which of the following drug inhibit 5-deiodinase enzyme except? Now remember, what is the action of 5-deiodinase? 5-deiodinase converts T4 to T3 hormone. This is known as peripheral conversion. This is known as peripheral conversion of T4 to T3 hormone at the level of cell because T3 is the active form of thyroid hormone. So any drug which inhibit 5-deiodinase enzyme will inhibit peripheral conversion of T3 to T4. And the drug names you have to remember is very important is PPID. How many drug? PPID. The first drug is a beta blocker, propranolol. Beta blocker inhibit T4 to T3. We discussed in autonomic nervous system. Second drug is propylthiouracil. Then we have is iodides like potassium iodide, Lugol's iodine. And the last drug which can also inhibit is corticosteroid like dexamethasone. And a follow-up information I want to give you that these drugs are given in the treatment of emergency thyroid storm. These drugs are given in the treatment of thyroid storm. Remember, as we are going from up to down, the first drug to be started in thyroid storm will be propranolol. It is the overall drug of choice. Then we add PTU. If it is still resistant, then we add iodides and dexamethasone. So here the answer is radioactive iodine. Okay. So Which of the following drug is the fastest acting anti-thyroid drug? The fastest acting anti-thyroid drug is iodides like Lugol's iodine. Why? Because these drugs they inhibit release of T3 and T4 hormone into the blood from thyroid gland, and release of T3 and T4 which are stored in thyroid gland, when they are released into the blood, it is the rate limiting step of thyroid hormone. Rate limiting step of action of thyroid hormone is release. Iodides like Lugol's iodine inhibit release. That is why they are the fastest acting drug. That is why they are given before surgery. Why? To make patient euthyroid normal, to reduce the size of thyroid gland so that we can reduce the risk of laryngeal nerve damage like external laryngeal and recurrent laryngeal nerve damage. Okay. Thyroid storm in pregnancy, again, life of a mother is more important. Thyroid emergency, thyroid storm is an emergency. Tell me, Sukriti ji, will you change any drug? If there is an emergency situation, would you see whether the female is pregnant or not pregnant? You are more concerned for the life of a mother or fetus. We are always more concerned with the life of mother. Arrhythmias can happen. You have to give propanolol. Okay, then you have to give PTU, even if it is a problematic drug. But thyroid storm is an emergency situation. So, what is a physical half-life of radioactive iodine 131? Radioactive iodine 131 is given to kill thyroid gland, destroy thyroid gland. Remember, it's a factual question, 8 days. Okay. Now, radioactive iodine, it destroys thyroid gland. So that is why if a patient is unfit for surgery or thyroidectomy, like old age patient, heart disease patient, instead of doing surgery, we give the patient radioactive iodine to destroy thyroid gland, like in thyroid cancers, toxic goiter, etc. So how radioactive iodine 131 destroy thyroid gland? By beta rays. So remember, beta destroy, okay, beta destroy. So which of the following is not used in the management of thyroid storm patients suffering from asthma? So beta, I have told you thyroid storm PPID. Remember, propranolol is a beta blocker, and in autonomic nervous system we have discussed that beta blocker are contraindicated in asthma. So if beta blocker are contraindicated in asthma, replace them with calcium channel blocker. Replace them with calcium channel blocker because they will also prevent arrhythmia on heart, which is seen in thyroid storm. So two calcium channel blocker which can be used as a replacement for beta blocker is verapamil, and second is diltiazem. This was a question of last year NEET exam. Verapamil and diltiazem will use as a replacement. So go with the answer which is not used. So not used will be propranolol, and you will replace propranolol with diltiazem. Replace it with diltiazem. Yes, we use diltiazem. Na? That is why the answer is C. So recombinant parathyroid hormone which is used in the treatment of osteoporosis is very easy to identify. Parathyroid hormone. Can you pronounce these drugs and tell me which drug is having parathyroid or para word in it? Can we say teriparatide? It is having parathyroid word in it. So it is the recombinant form of parathyroid hormone which is used in the treatment of osteoporosis. Now what is denosumab? How we can remember denosumab? First, it's a monoclonal antibody. Then you can see den word is coming. Den means it increase bone density of bone, and density of bone becomes very weak in osteoporosis. So you can see a word word is coming. OS means denosumab is also given in the treatment of osteoporosis. Now how it acts? Denosumab inhibit rank ligand. Rank ligand is a molecule which activates osteoclast. So by inhibiting rank ligand, it blocks the activity of osteoclast. Bones will not get destroyed. Any drug that ends with the word dronate, like alendronate, pamidronate, ibandronate, zolendronate. Dronate word will come. Any drug that ends with the word dronate will be a bisphosphonate, which are considered to be the drug of choice for osteoporosis. And any drug that ends with the word phene is an SERM. Raloxifene, tamoxifen, clomiphene, selective estrogen receptor modulator. Okay, so let's talk about which of the following drugs causes osteoporosis in long term. The two main causes of osteoporosis is the first is postmenopausal osteoporosis, and the second most important cause of osteoporosis is Cushing syndrome. Now, can you tell me why postmenopausal osteoporosis happen? Because of deficiency of estrogen. Estrogen is good for bone. So, would you think OCP? Remember OCP, oral contraceptive pills which contains estrogen, they reduce the risk of osteoporosis. And Cushing syndrome means excess of corticosteroids. So, let's say a patient is taking corticosteroid prednisolone from outside. Long-term intake of corticosteroid like prednisolone can lead to osteoporosis. So the answer out here is B. So the drug which promote bone formation in osteoporosis is, the answer is teriparatide. Remember teriparatide, it stimulates osteoblast. Because it stimulates osteoblast, it causes new bone formation and the bone density will increase. And rest any other drug in osteoporosis, remember, they inhibit osteoclast. That means they decrease bone destruction. They inhibit bone destruction. Destruction is also known as resorption of bone. Okay, so answer here is teriparatide. So what advice you will give to a patient who is to be treated with alendronate? Alendronate, remember, is a bisphosphonate. So what are the side effects of bisphosphonate? Remember, side effect of bisphosphonate, you can remember a mnemonic ROSE. You can remember a mnemonic ROSE. First, it causes renal failure. So avoid giving bisphosphonate in renal failure. So this is a true statement. Bisphosphonate can damage the bone of mandible. They can cause osteonecrosis of mandible or jaw. So can we say true? Third statement is also true. Now they can cause subtrochanteric femur fracture. Now if you give bisphosphonate for more than 10 years, if you give bisphosphonate for more than 10 years, they increase the risk of which fracture? Subtrochanteric femur fracture. So what is the maximum duration you can give bisphosphonate to your patient? We give bisphosphonate maximum for 10 years, not 2 years. So this is a false statement. This is a false statement. Now this question came basically beta last year in INICT exam. Now bisphosphonate, they damage esophagus and they can cause esophagitis. So that is why when a person takes oral bisphosphonate, patient should not eat anything. Patient should remain upright for next 30 minutes and take bisphosphonate with plenty of distilled water so that from esophagus it goes back into the stomach and down into the intestine. It should not get reflux back to the esophagus, otherwise they will damage esophagus. So yes, it should be given with a glass. With drug should be taken before meal at least 30 minutes with glass full of distilled water. Okay? Okay? I hope you have understood. Remember, a very commonly asked question. Now, this question also came last year in your NEET or probably INICT exam. Okay? A 60-year-old postmenopausal female, previous history of fracture like Colles fracture, came with the complaints of lower backache, some spinal problem would be there. Now T-score, you know, is a score which we do on DEXA scan. And DEXA scan, if the score is less than 2.5, we call it as osteoporosis. So yes, the patient is suffering from osteoporosis. So which of the following statement are false about the management of our condition? So let's start from D. Denosumab is preferred in kidney disease patient. True. Remember, any monoclonal antibody, this is a rule, is always safe in renal failure. Because monoclonal antibodies are proteins. Proteins are not excreted out in urine. They are removed by macrophages. So denosumab safe in renal disease, absolutely true. Teriparatide should not be given for more than 2 years. Again, true statement. Because for more than 2 years, if you will give teriparatide, it will increase the risk of one cancer of osteoblast, which it was stimulating. It increased the risk of osteosarcoma. Bisphosphonate are never given for more than 10 years. Yes, we have just discussed. Otherwise, they will increase the risk of subtrochanteric femur fracture. Last is the false statement is A. Teriparatide, which is a parathyroid hormone, is given as a continuous injection, absolutely contraindicated. Remember, if you give teriparatide as a continuous injection, it stimulates osteoclast, it destroys bone. And same parathyroid hormone, if you give as an intermittent or pulsatile injection, it stimulates osteoblast. So tell me, in the treatment of osteoporosis, how would you like to give teriparatide? You want to stimulate osteoclast or osteoblast? Yes, we want to increase bone mineral density. We want to stimulate osteoblast. So that is why parathyroid hormone, teriparatide drug is always given as an intermittent injection, never as a continuous injection. Okay, remember that part. So which of the following is a false regarding somatropin? Soma means growth, tropin means growth promoting hormone. So it's a growth hormone. Remember, somatropin is a drug of choice for the treatment of dwarfism. Yes, before epiphyseal closure. Growth hormone is a pituitary hormone, we all know. Remember one rule. All pituitary hormones, they produce hyperglycemia. All pituitary hormones are opposite of insulin. Okay, all pituitary hormones are opposite of insulin. They rather produce hyperglycemia. So growth hormone rather produce hyperglycemia. Any drug which is a pituitary hormone is always given by injection because they are peptide, and due to excessive growth, the nerve entrapment will happen. So which drug causes a side effect of carpal tunnel syndrome? Yes, growth hormone causes carpal tunnel syndrome because of excessive growth of tissues. Nerve entrapment happen. Okay, so now let's talk about, thank you Harsh ji, don't be fan, just पढ़ाई करो अच्छे से पढ़ाई करो, है ना. Cabergoline is indicated in following condition. Now beta, let me tell you, you have heard about a drug bromocriptine. The big brother of bromocriptine is cabergoline. Both bromocriptine and cabergoline, remember, they stimulate dopamine receptor on pituitary, or you can write they stimulate dopamine receptor in brain. Remember, if you stimulate D2 or dopamine receptor on pituitary, it decreases prolactin secretion. Dopamine suppress prolactin production. And if you stimulate dopamine receptor in basal ganglia, can we say they can be given for the treatment of Parkinson's disease? Because in Parkinson's disease, there is deficiency of dopamine in basal ganglia. So these are the uses of these drugs. Let's talk about which of the following condition is false except. Okay. Okay. I hope you're enjoying this part. You're understanding each and every concept what I'm teaching you, because I'm going a little bit fast with you. So, can we give these drugs for the treatment of prolactinoma tumors? Yes, they are the drug of choice for the treatment of prolactinoma. Overall drug of choice is cabergoline because it is more powerful or more potent drug. But prolactinoma occurs in pregnancy, then we give bromocriptine. Now, we know if we suppress prolactin production, last year NEET question, which drug is given to suppress prolactin production or to suppress breast enlargement or breast engorgement in a mother after neonatal death? After neonatal death, we don't want the mother should produce milk. It is useless. So we give this drug. And remember, and if we reduce prolactin production, the side effect of this drug will be, oh, sorry, even this is also correct. Even this is also correct. Okay, so if we decrease remember, increase in prolactin, increase in prolactin causes a side effect of amenorrhea, and increase in prolactin causes anovulation infertility. So that is why these drugs are given for the treatment of amenorrhea and infertility. These are the features of prolactinoma tumor. So that is why we never give in the treatment of amenorrhea and galactorrhea. They are given in the treatments. Oh, so I think there is some mistaken out here. Yes, they are given in the treatment of amenorrhea and infertility also. I think all the options are correct. So probably some all the statements are true. Okay, so I can't tell you the false statement out here. Okay, all statements are true. So octreotide and lanreotide, remember. Okay, so any drug which ends with the word reotide, remember a trick, any drug that ends with the word reotide is a somatostatin hormone. So can we say octreotide, lanreotide, they are somatostatin tumor? And where these drugs are used, remember, these drugs are used in the treatment of bleeding esophageal varices. Yes, we use octreotide, but now the better drug is terlipressin. And somatostatin is an inhibitory hormone. It decreases the production of all other hormones like serotonin, which can lead to carcinoid tumor. So yes, they are the drug of choice for carcinoid tumors, which can lead to secretory diarrhea. Don't you think they will also decrease the production of insulin, glucagon, and gastrin hormone? Insulinoma, gastrinoma, glucagonoma. These three tumors together, they are known as pancreatic neuroendocrinal tumor or PNET tumor. So for the treatment of PNET tumor, the drug of choice is octreotide and lanreotide. Now the question is except it is gallstone. Remember, octreotide itself produces a side effect of gallstone. It is not given for the treatment of gallstone. The reason is octreotide decrease CCK production also, cholecystokinin, which decrease gallbladder motility. Decrease in gallbladder contraction will lead to deposition of cholesterol and bile. It itself can cause gallstones. So now the pulsatile use of leuprolide includes all of the following except. Now what is leuprolide? Remember this drug, you have to remember, it's very, very important. Many times the question come. Leuprolide is gonadotropin releasing hormone. It is gonadotropin releasing hormone. And remember, when we give gonadotropin releasing hormone as a pulsatile injection, as a pulsatile injection, on pituitary when they will act, they will increase FSH and LH secretion. But same gonadotropin releasing hormone, just like parathyroid hormone teriparatide, if I will give continuous injection, the receptors of gonadotropin will stop responding because you are giving continuously. They will become desensitized, and now the pituitary will decrease the production of FSH and LH hormone. So remember this concept. Pulsatile injection of leuprolide increase FSH and LH, while continuous injections will suppress it. Now, in which condition you want to give pulsatile injection? So, pulsatile injection is given in anovulation. Yes, because FSH and LH in female will promote ovulation. They are given in the treatment of azoospermia because in males it will increase spermatogenesis, sperm count, FSH hormone. They are also given in precocious puberty. Yes, in precocious puberty, there is a deficiency of GnRH. So hence the answer is where it is not used. The answer out here is prostate cancer. Remember, in prostate cancer, we give continuous injection of GnRH. They are the drug of choice for prostate cancer because we want to decrease testosterone production. And prostate cancer is a testosterone dependent cancer. Okay. So in which condition we want to decrease FSH and LH? prostate cancer. So let me tell you, they are the drug of choice for precocious puberty. Sorry, I'm really sorry. Oh, both. You're absolutely right. You're absolutely, again, a incorrectly framed question. Both. They are the drug of choice for delayed puberty. Because in delayed puberty, you want to increase FSH and LH level. And when you are giving as a continuous injection, they are also the drug of choice for precocious puberty. They are also the drug of choice for precocious puberty. So both C and D are the continuous use of GnRH hormone. Yes, you are absolutely right. C and D is the correct answer. Yes. Okay. So because I'm engaged with you, so I sometimes can't read the question properly. So it happens when you are teaching, you are more interacting with students. So sometimes you don't read the question properly also. So important difference between leuprolide. Remember, leuprolide stimulates gonadotrophin releasing hormone. It is the gonadotrophin releasing hormone. So it is ending with the word leuprolide. But remember, any drug that ends with the word relix, like ganirelix, cetorelix, digarelix, sabarelix, they block gonadotrophin releasing hormone. They are antagonists. Now the point is, remember this part, because they are antagonists, they only decrease FSH and LH because they are only blocking the receptor. While leuprolide, when given as a continuous injection, as a pulsatile injection, it increases FSH and LH. When it is given as a continuous injection, it decreases FSH and LH. But understand this word, that when we give leuprolide as a continuous injection, FSH and LH will fall just like digarelix and ganirelix. There is an important difference you have to remember. I have just told you, when we give leuprolide, they decrease FSH and LH, continuous administration, because of desensitization of receptor. The receptors will stop responding. But remember, receptors, they stop responding after 7 days. Initial few days, the receptor will respond, and desensitization will happen after 7 days. So when you give continuous injection of leuprolide, initially there is increase in FSH and LH level because right now the receptors are responding. Later on, the FSH and LH level will fall in continuous administration. While with the Relix Valley drug, they will only decrease. They will only decrease FSH and LH level. So this is the basic difference between these drugs. So understand, all these drugs are given by injection. Any pituitary hormone I have told you is given by injection. Okay. They reduce androgen production. Yes, ganirelix and leuprolide both can reduce androgen production if it is given continuously. They must be given as a pulsatile fashion, we will see. So this is the correct statement. The most important statement is this one. Okay. That leuprolide causes initial stimulation of FSH and LH, while ganirelix causes only decrease in FSH and LH production. So which is the longest acting, most potent, and pure glucocorticoid? Pure glucocorticoid means with no mineralocorticoid activity. The answer is dexamethasone and betamethasone. So crack it, remember it. They are the longest acting, most powerful, and pure glucocorticoid. Now remember, hydrocortisone is the shortest acting drug, and it has both glucocorticoid and mineralocorticoid activity. Hydrocortisone has both glucocorticoid and mineralocorticoid activity. Corticosteroid with maximum sodium retaining potential. Sodium retaining potential is just like mineralocorticoid, like aldosterone. Mineralocorticoid causes sodium retention from kidney, and that drug is fludrocortisone. So fludrocortisone is a mineralocorticoid given in the treatment of hypotension. In adrenal insufficiency due to Addison's disease, congenital adrenal hypertrophy, which drug to be given? Remember, if adrenal gland, it is not making, if it is not working, we call it as adrenal insufficiency. Certain causes are Addison's disease, CH. That means there is no production of glucocorticoid, there is no production of mineralocorticoid. Can you tell me, beta, why the drug of choice for adrenal insufficiency is hydrocortisone? I have just told you the reason. Why the drug of choice for adrenal insufficiency is hydrocortisone? Because hydrocortisone has both glucocorticoid and mineralocorticoid action. It can give given as a replacement for both hormone as a single drug. Okay. Now, all are the side effects of corticosteroid. Please learn from physiology the side effect of corticosteroid. They are known as Cushing syndrome. It's a very frequently asked question. So yes, corticosteroid, they are catabolic hormone. They will cause bone destruction, osteoporosis. Yes, cataract and glaucoma. Remember cataract. Which type of cataract is seen? Posterior subcapsular cataract. Posterior subcapsular cataract. Moon-like faces and central obesity. Yes. Now corticosteroid, remember, they rather produce hypertension. Why? Because they have mineralocorticoid activity, they cause sodium retention. And if there is high level of sodium in the body, it will increase blood pressure. Okay. In precautious, we have to decrease FSH and LH, Karthik ji. So we give continuous administration of gonadotropin releasing hormone. Now steroids are contraindicated in, remember steroids, they are given in infection. We give steroids in infection. Contrary, we believe that steroids should not be given in infection. They reduce immunity, yes, but steroids are the mainstay of infection treatment, but they are always given with antibiotics. Now, why we give steroids in infections? Because steroids are anti-inflammatory molecule. And why we give? We give steroids in infection to reduce fibrosis, which occurs during infection, and edema, which can occur in infection. So let me take you an example. Tubercular meningitis. Don't you think if TB occurs in meninges, it will lead to fibrosis and edema? Fibrosis and edema will lead to compression of brain. Patient may die. It is mandatory to give corticosteroid in tubercular meningitis. Similarly, they are the drug of choice for Bell's palsy. We discussed. And they are also given in premature newborn. Why? To cause fetal lung maturation. And for fetal lung maturation, either we give dexamethasone or we give betamethasone. In India, we prefer to give dexamethasone. In the guidelines, it's a cheap drug, easily available. 6 milligram, 12 milligram. Okay, intramuscular injection. Because in fetus, it will lead to lung maturation by surfactant production. Now remember, glucocorticoids are never given in one infection. Glucocorticoids are never given in intestinal TB. They are also contraindicated in herpes corneal ulcer or herpes keratitis. So two infections where we don't give corticosteroid is intestinal TB, because here we want fibrosis should happen. If you will inhibit fibrosis in intestinal TB, TB bacteria will perforate intestine and it will come outside. Never give corticosteroid in which two infection? Intestinal TB and herpes keratitis. Okay, perforation can happen. So which of the following is a glucocorticoid receptor blocker? The drug which is a glucocorticoid receptor blocker is mifepristone. So remember, mifepristone blocks two receptors. It blocks glucocorticoid receptor. It also blocks progesterone receptor. Because it blocks glucocorticoid receptor, it is given in the treatment of Cushing syndrome. Because it blocks progesterone receptor, progesterone is a hormone of pregnancy. If you block progesterone, pregnancy will terminate. It is given for MTP or medical abortion. It is also given for treatment of hyperproliferative diseases, which is due to progesterone, that is endometriosis. Now remember, mifepristone is having pris word in it. Another drug having pris word in it is ulipristal. Ulipristal, remember, it only blocks progesterone receptor. It does not block glucocorticoid receptor. And this ulipristal, it is given as an emergency contraceptive pill. A very commonly asked question. It's an emergency contraceptive pill which is taken after unprotected sexual intercourse. Its dose is 30 milligram, which is taken once within 5 days. within 5 days of unprotected sexual intercourse. You will give ulipristal. Remember, very important. Another name of misoprostol is RU486. Misoprostol is also known as RU486. It is a chemical name. It was a name which was given to mifepristone when it was at a stage of clinical trials. When it was not approved, we call it as RU486. Later on, it got approved. The name has been changed to now mifepristone. So, which of the following drug is used for medical adrenalectomy? Medical adrenalectomy is done in cases of inoperable, when you can't do adrenalectomy or adrenal tumors. When you cannot remove adrenal tumor, give drugs to reduce the production of adrenal hormone. Remember three drugs which are now most commonly used. MOM. The first drug is metotane. Metotane, very commonly asked question. A new drug recently got approved, osilodrostat. If you can't remember osilodrostat, it's fine. And the third drug which you have to remember is metirapon. So drug you have to remember. They are the drug of choice for adrenal tumor because these drugs, they inhibit one enzyme in adrenal tumor known as 11 beta hydroxylase enzyme. That is why they will decrease the production of corticosteroid in adrenal gland. They are given for adrenal tumor. The answer out here is metotane. Don't forget it. It has been asked many times. Okay. Yes, if there is no fibrosis, it will lead to perforation of intestine. So Gayatri ji, don't you think if you will give corticosteroid, fibrosis will not happen? If fibrosis will not happen with corticosteroid, intestinal perforation will happen if we use corticosteroid during intestinal TB. So that is why corticosteroid are never given in intestinal TB. They can lead to perforation. Understood this part? Now there is a drug known as danazol. Danazol. So when you will pronounce this word danazol, can you tell me any famous villain which is from northeast part of the India comes to your mind? Okay. Yes, they both are given Grace gene, Cushing syndrome also, metotane and metirapon. So heard about any famous villain, very famous villain, but he was a very good human being also. Apart films, we are different, but actually he was a very good human. Yes, Grace G, Danny. You have heard about Danny. So when Danny comes, remember there is a drug known as danazol. Can we say Danny was a villain, male villain? So danazol is a drug which will stimulate your testosterone receptor. So he was a villain who used to feed on girls, है ना? So it stimulates testosterone receptor. And danazol is an anti-female. The Danny was anti-female. It blocks estrogen receptor. So it's a drug which stimulates testosterone and block estrogen. So where danazol is used, can we say danazol is given in the treatment of fibroid and endometriosis? Yes, because it blocks estrogen receptor. It is also given in the treatment of menorrhagia because danazol stimulates testosterone receptor in females. In females, the side effect of danazol will be hirsutism and acne. So it is not used in the treatment of hirsutism and acne. It is rather produce a side effect of hirsutism and acne. Okay. Yes, we can give ketoconazole also, but nowadays rarely used. It is a drug which has been approved. Okay. Other drugs, mifepristone has also been approved. Other drugs are also there, which I have told you. But right now, you just have to remember important drugs which are asked in your exams. So which of the following statement regarding finasteride are true? So beta, this drug I have already told you in autonomic nervous system also, steroid is coming. It is a 5-alpha reductase inhibitor. That means it inhibits the conversion of testosterone into dihydrotestosterone, which is the active form of testosterone. So that is why finasteride I have told you is given in the treatment of BPH, benign prostate hypertrophy, because decreasing DHT level will reduce prostate size. Now impotence, if you will decrease testosterone active form, obviously in males there will be erectile dysfunction or impotence. So yes, impotence can happen with finasteride. Now it blocks the conversion of DHT to testosterone. Now this is a false statement. It's opposite. Remember, it's opposite. D is also true. Okay. A 5-alpha reductase inhibitor that has been found in both benign prostatic hypertrophy and male pattern baldness is Finasteride, we have already discussed. So finasteride, it has also been approved for male pattern baldness, which is also known as, first use is BPH, second use is androgenic alopecia. In androgenic alopecia, remember, we gave finasteride along with minoxidil cream. So this is the treatment in androgenic alopecia. The cream concentration is 2 to 5% cream, which is applied on scalp to promote hair growth. Finasteride, dutasteride with minoxidil combination, androgenic alopecia, 2 to 5% cream applied on scalp. Now, which of the following is not an SERM? SERM beta stands for selective estrogen receptor modulator. And any drug which is a selective estrogen receptor modulator, it will end with the word phene or phene. They will end with the word phene. If you pronounce it, it will be phene. So can we say ormeloxifene, tamoxifen, raloxifene? They all are ending with the word phene. So the answer out here is fulvestrant. Fulvestrant is SDRD. SERD. It is selective estrogen receptor down regulator. Down regulator means it blocks estrogen receptor at all sites of the body. That is why it is known as ESTR, means estrogen receptor antagonist. Full means at every site. So this ormeloxifene, remember, it is also known as centchroman. Ormeloxifene is also known as centchroman. It comes with a brand names Saheli and Chaya. And it is a made in India drug. This question is for FMG student. It's a made in India drug made by CDRI Lucknow, Central Drug Research Institute. And this ormeloxifene or centchroman, it is used as a contraceptive. Once a week contraceptive. Tamoxifen, it is given for the treatment of breast cancer. Raloxifene is given for the treatment of osteoporosis, especially post-menopausal osteoporosis. Now, one question comes, among tamoxifen is given for the treatment of breast cancer. Any student who can tell me, tamoxifen itself increase the risk of which cancer? Tamoxifen itself increase the risk of which cancer? Endometrial cancer. Tamoxifen given for the treatment of breast cancer, but itself causes endometrial cancer, and this endometrial cancer is not seen with which drug? Endometrial cancer risk is not seen with raloxifene. It is only seen with tamoxifen. So regarding raloxifene, which of the following statement is incorrect? False statement. It reduced the risk of osteoporosis. Yes. It also reduced the risk of breast cancer. Okay. And remember, this is a false statement. It does not reduce the risk. It is a neutral drug. Neutral drug. Okay. It will not increase. It will not decrease. One student was asking me this question. It was asked. And it can induce or aggravate post-menopausal hot flushes. The main side effect of raloxifene is hot flushes. So which of the following drug is a aromatase inhibitor? So any drug that ends with the word, any drug which ends with the word zole or meschain are aromatase inhibitor, like letrozole, vorozole, exemestane, formestane. But you have to remember which drug? Letrozole. So letrozole is an aromatase inhibitor, and aromatase inhibitor, what is the function of aromatase enzyme? Aromatase enzyme normally converts testosterone into estrogen, and aromatase inhibitor will inhibit the conversion of testosterone into estrogen. This is the only source of estrogen in postmenopausal female. Postmenopausal female, their ovaries are not working. So they require estrogen. That estrogen comes from testosterone. Testosterone is produced from adrenal gland in a postmenopausal female. So if we reduce estrogen production in postmenopausal female, these drugs are the drug of choice for postmenopausal breast cancer. They are the drug of choice for postmenopausal breast cancer. And letrozole, just like clomiphene also clomiphene and letrozole. They both drug are given for ovulation inducer. Letrozole and clomiphene, they are given as an ovulation inducer also, like in cases of PCOD, during in vitro fertilization when you want to extract ova. So these are the main uses of letrozole. Post-menopausal breast cancer, they are the drug of choice. Sir, what is the drug of choice for premenopausal breast cancer? Premenopausal breast cancer, give tamoxifen. Premenopausal tamoxifen. Postmenopausal breast cancer, aromatase inhibitor, letrozole. So this finishes our session of endocrine. I wish you very best for your exam tomorrow, FMG exam tomorrow. So, but our series will continue because NEET exam is also approaching on 3rd of August. So the remaining few units we will also cover. Best wishes everyone for FMG aspirant for your exam. Make yourself, your parents, your friends proud. Be calm. Keep your mind very much silent. Remain focused. Don't worry. Don't have any type of anxiety that, sir, probably I will forget this, forget that. Don't worry about that. It is just an exam. And remember, your life is more important. Exams, they are just the part of life. Even if you fail one exam, you are not a failure. And even if you pass an exam, you cannot become a god also. So remember, it is a journey which you have to feel. So don't be anxious. Just go like any other normal day. Just give it as an exam, just like any other normal exam. And surely, when you don't have stress or anxiety, you perform better. Okay. So best wishes. So don't worry, beta. I'll tell you which next unit we will uh, do. Okay, probably NEET is coming, so I'll start with anti-cancer probably or CVS probably because these are the two main units which are remaining. Okay, so best wishes. Take care. Remain calm. Remain composed. Be happy. Don't fear for the result what it might be. Okay, fear is not good for health. Okay, sure. Best wishes.